Hi class, this is the lecture video on the Priest Transgender Ethics series of articles. And I wanted to mention two things about them, just they're worth noting. First of all, notice that the readings are all online. One of the funny things that happens in medicine is things can change rather quickly. It's a dynamic field, there's always new issues coming up. That's the nature of the beast, and if that's something that you're not necessarily comfortable with, you might want to reevaluate a few things. But um, even the fifth edition of the textbook, which is just a couple of years old, just does not have sufficient transgender ethics coverage. So I had to add some articles. And uh, secondly, you'll notice if you haven't done the reading yet, especially, it's worth noting the the priest article is set up as a symposium, and what that means is the long article, the big article, is priests, where she puts forward her argument about state care for transgender ethics. And then there are some respondents. There's actually more than I assigned. If you're interested, you could go look up the other ones. But we're focusing on two respondents and then priests' responses to those respondents. And so the bulk of the philosophical, ethical heavy lifting is with the first article, uh, transgender children and the right to transition. The first thing I want to say about it is, um, the place where transgender ethics is running into opposition has to do with what's often called parental rights. That when the child says one thing and the parent says another thing, what happens? Well, the most important bit, the big central thesis is we already have these in medicine. There are clear guidelines and policies and procedures and even laws that focus on what happens and when it's the state's duty to protect the child over the wishes of the parents. So if you think of abuse cases, parents who want to deny life-saving medical care, things like that, there are guidelines involved for when the state should take action. And big picture priests' ultimate thesis is, and certain types of transgender care meet those criteria. And if that's true, that means the state has an obligation to do certain things in certain cases, even if uh, parents oppose. And so, how does she do that? There's several steps involved, but they're not particularly difficult. They might be controversial, but they're not difficult. So, one, she very rightly and obviously points out that psychological harm is a type of harm. And it's a serious type of harm, and it's akin to physical harm. And again, outside of transgender ethics, that's not a particularly controversial view. There's laws against psychological abuse, just as the same as there's against physical abuse, etc. And so, uh, the way she's going to motivate why this type of psychological harm is so serious is to tie it with suicide rates. And so, first of all, what is someone who's transgender? Not to make any assumptions here if you don't know, this is when someone identifies as a gender other than that of their biological sex. Okay, no problem there. That's fine. But there's an associated medical condition. Let me emphasize this is a medical condition called gender dysphoria. Gender dysphoria is when being transgender causes certain types of psychological distress. And so uh, Priest and others, AMA, etc., consider this a medical issue. Uh, Among other things, someone who is suffering from gender dysphoria, is 10 times as likely, 10 times as likely to commit suicide. And so, right there, a priest is going to claim, and this is where the issue shifts to a matter of health, a matter of state duty to protect children from severe harm. And she's going to formalize that as a three premise argument with a conclusion. So If you need to brush up on your argument stuff before looking at it, feel free. But here's the formal argument. Premise one, it is a state duty to protect um, children from serious harm, even by their caretakers. That is the non-controversial premise. Everybody says, of course. Well, not everybody, but it's pretty well established ethically and legally. Two, harm that leads to suicide is a serious harm. Three, being transgender without support is a high risk of suicide. Conclusion, the state should protect in these cases, although we haven't laid out exactly what that protection would look like. But that's the argument. And notice, first premise is relatively non-controversial. The question is whether something that is high risk of suicide counts as harm, is really the main issue there. And so, in theory, that should be the point of discussion. It is generally not, but at least with this type of reasoning. So, she's going to unpack this a little more. And a lot of the issue has to do with puberty. So, okay, you're in some sort of medicine related class. You probably know what puberty is, but relevant here, of course, is that puberty is when you develop your secondary sexual characteristics. It is when biological sex becomes truly defined permanently and irrevocably in some sense. And what that means is, first of all, that puberty extremely exacerbates gender dysphoria. And it's something that people could see coming a long way off, whether it be the child, the doctor, etc. We know that puberty will happen. We know that it will lead to this development of secondary sex characteristics. We know that that does severely exacerbate gender dysphoria. Now, the usual process here, and I want to be very clear about this because there's this false narrative among the far right sometimes, is that what the usual step is here is that a doctor will prescribe puberty blocking treatment. That is, they will it is possible to chemically prevent puberty from happening, and then blocking allows for the child to mature mentally and at the same time not have anything permanent and irrevocable happen, so that they can decide when they're mature and legally able to do so if they want to transition. There is not, to my knowledge, any state that allows sex reassignment surgery on minors. It's the treatments have to do with these puberty blockers. I could be wrong about that. That's a legal point, but to my knowledge, there's not. And so the usual talk about, the usual procedure is about puberty blocking. If you start hearing a bunch of, children being mutilated and stuff, that's probably just it's either a distortion or an exaggeration for propaganda purposes. That's not really what happens. So there's that. And when these kind of things are available, along with being supportive, non-judgmental, and offering counseling, we see suicide rates drop. So says Priest. And so, as such, what she's saying is the state should allow and encourage and educate about these types of treatment, and it is a treatment, and it is a medical treatment. So, because otherwise we end up with these harms from forcing the gender dysphoric youth from going through puberty. And she talks about that some on 51. She says, one, we know that puberty causes serious harm in gender dysphoria. And two, this harm is long term and may be irreversible. And three, we know the exact cause of this harm in gender dysphoric youths. And what she's going to say is this meets the textbook definition for when the state should intervene on health matters. She says that the state and should intervene when one, there's potential for serious harm, but that's not enough. Two, there has to be a high likelihood of serious harm. And three, there has to be sufficient evidence of those two things. She thinks that having gender dysphoric youths go through puberty, she thinks that well, obviously suicide's a serious harm, but two, she thinks it's a sufficiently high likelihood, and three, she thinks the data is there in terms of linking these two, and for these reasons, she thinks that the state does have an obligation to intercede in these cases. She says public schools are a good vehicle. She says that religious parental rights are not absolute, and they can be trumped when it comes to the three things just mentioned. So that is the priest initial article. And yeah, I guess that's what I want to say about that specifically. But then reminder, there's two response articles, and then she will eventually reply to those as well. So the Baker article, she has three concerns that she doesn't like about the priest article. One is that priest's language tends to be exclusively binary, and she thinks that making that kind of case in a binary leaning way threatens to delegitimize non-binary who are not always transition oriented. Two, she thinks that the doctor's she thinks the doctor's unilateral decisions are not always appropriate, and that sometimes when parents should have the right to kind of disapprove of these things. And then three, she worries that the one of the big things that Priest leans on, that puberty blocking treatment, the link between that and suicide is not, or I should say absence of it, and suicide are not well established. So for instance, imagine a sadly all too common situation where there is somebody who's transgender, they do commit suicide. It's hard to establish that in that case, the counterfactual, that they would not have committed suicide if they had access to this treatment. That's the harder part. Now, of course, it's not that that's impossible. It's just those Baker thinks that the current body of data is lacking. So those are her three worries. Laidlaw et al. Raise a different kind of worry. This group seems to be particularly anti-transgender treatment, and they're really basing it on 2 points. One, and most importantly, is that puberty blocking agents are often off-label uses for medications, and there's some negatively associated potential side effects. There's worries that it can lead to sterility. There's worries that can also impair sexual function severely. And these worries are, again, of side effects, especially of someone who takes the puberty blocker and decides not to transition eventually. So that, and then it can also cause depression. And that's, by the way, that's one of the hardest ones for me as a philosopher to adjudicate, because Now we're talking about uh, the body of data within the scientific community, which is a question for the sciences, not a question for ethics. But those are certainly relevant things to pay attention to. I'll put it as a hypothetical. If it is the case that the data legitimizes these worries, then that's something we have to take into account. And then, so there haven't been controlled studies on puberty blocking agents used for this particular purpose, etc. So that though the Laidlaw et al. Raises a different kind of concern. Uh, I would strongly recommend neither agreeing with them nor disagreeing with them unless you familiarize yourself with those kind of literature and studies, because otherwise we're whistling against the wind a little bit. Having said that, let's turn to Priest's responses to see how we can start to look at these things. Uh, and she makes two major and important points, and I would add a third. But uh, thing one, Priest points out that puberty blocking treatments have been used for decades. This is not this new and innovative thing. We've been doing it for quite a while, which seems to establish and go some way towards there. If there are these types of worries, they're relatively minor. And minor in the sense that if they come at all, they come with a very low frequency. But two, and this is something that is worth remembering generally, because sometimes in just contemporary culture we lose sight of this. These things don't happen just because a kid wants to. They don't happen just because a parent wants to. They happen when a medical professional suggests and approves the treatment. It's just like any other um, major procedure that cannot be done over the counter. And so, in a perfect world, and I want to be very careful about this, in a perfect world, that means that um, this is someone who's not giving into pressure, and they're using their medical judgment and only their medical judgment to make these kind of decisions. And in that case, then those are the kinds of things we trust. So to give an analogy, well, we do trust doctors to prescribe medications that have potential side effects. The fact that a doctor is approving it means that a medical professional who is informed and is aware of the risk of the medication, of the treatment, of the surgery, etc., uses their medically based decision, which includes considering all the risks involved, and ultimately decides in their professional view that the benefits of the treatment outweigh the risks. And so long as those risks are clearly uh, explained to the patient, there in any other field, in any other aspect of medicine, this is not a problem. This is business as usual. Well, of course, the reason things aren't over the counter is because they carry risks. And so Priest thinks that that kind of consideration is being skipped over, and yet it really has a lot of force. That this is something that only happens when a medical professional, in their professional opinion, approves it. The third thing I will add, I'm not going to comment on what the literature says overall about the puberty blocking agents and their side effects. I will say that the journal this was published in is a high quality journal. Everything is peer reviewed. I think that if Priest was way off base about her claims, it would not have been published. And so I have some inclination to think that uh, even given the side effects, they're probably pretty minimal. But again, that's just based on what I know about the journal. And I thoroughly encourage you, especially if you're the type who is qualified to read medical journals, to go find out. Uh, but uh, when we are thinking about the risk, we think about it in terms of the risk of having them versus not having them, rather than the risk of of having them generally, and that's I think the most important part of priests' response there. Anyway, that's all I think I have to say for setting up those 4 articles. Otherwise, feel free. I hope to read some interesting papers and discussion boards about it. And as always, feel free to reach out with any questions. Uh, this topic, more than any other, I really want to remind you we are evaluating these as medical professionals because some people have some very strong personal opinions about those issues, and we have to check them at the door. Otherwise, we will see you next time.